Okay, so our next speaker is Dr. Shannon Jackson. Dr. Jackson completed her medical school, her internal medicine training, and her hematology training at the University of Calgary, and has been in Vancouver since 2009. Shannon practices at St. Paul's Hospital, is a clinical professor of medicine at UBC, and is the medical director of the Adult Bleeding Disorders Program of BC and Yukon. And Shannon will be speaking to us today about acquired hemophilia in British Columbia. Shannon, thank you very much.
Good morning, everyone. I'm honored to be asked to join this year's Earl Davie Symposium, and we're going to talk a little bit about something different, but still in the bleeding lane. I'm here on behalf of a lot of people who have collaborated. So one of the themes of this presentation is collaboration, which you all have to do a lot when you're doing research with clinicians, and also talking about health outcomes that matter to patients and value for both patients and the system. Here are my disclosures, which are limited for this particular talk. Acquired hemophilia A is the acquisition or a new state in a human where we can no longer reliably generate thrombin. And that creates bleeding symptoms that are new. As shown at the bottom of the right slide, these can be different. They can present as bleeding in the subcutaneous tissues, including losing up to several liters of blood in these tissues. The problem and the pathophysiology of this condition relates to the development of an autoantibody to the patient's endogenous factor VIII. You'll remember, if you've studied the coagulation cascade, that the clinical test, the PTT, is most sensitive to changes in this intrinsic pathway. So we see PTT prolongation in the clinical lab. This tends to occur in older patients, typically in their 70s, with brand new bleeding, no anticoagulants, and this prolonged PTT. We also see a small peak in pregnancy, typically postpartum. We know that in about half of cases, there's a driver, tending to be an autoimmune condition or a malignancy. We know that the mortality at 1 to 2 years post-diagnosis is about 20 to 30%. Half due to the bleeding itself, as the condition causes, or so a third due to that, a third due to the problems of immunosuppressing these patients, and a third due to other causes, typically age, comorbidity related, or a malignancy itself. While it doesn't contribute to mortality, about 5% of these patients can get clots because of the types of therapy we use. I'm going to talk to you about a case. This case is very recent, within the last couple of weeks. We had a patient transferred down to St. Paul's, a few kilometers away, from a large BC center, about 800 kilometers from here. 84-year-old patient, has a lot of comorbidities, most relevant, has type 2 diabetes, rheumatoid arthritis, and hypertension. Patient has spent 3 months in the region where they live with recurrent gastrointestinal, oral, muscle, and genitourinary bleeding in the urine. Eventually, a really important test was done to evaluate why the PTT was prolonged, and this was called a mixing study. The study did the classic behavior of when we see an antibody to factor VIII. The initial mixing study corrected, you add normal plasma, the PTT goes back to normal, but you incubate it at body temperature and the PTT prolongs again. A key test called a factor VIII activity was performed, and the factor VIII was undetectable. And then another test looking at detecting and then measuring the potency of the antibody responsible confirmed a high titer antibody of 65 Bethesda units. I want you to pay attention to the next part of this slide and imagine what this is like for the patient and family. In the 3 months prior to transfer and i.e. recognition of this disorder, the patient had gone through, as did their family, 3 hospital admissions, totaling 28 inpatient days, 9 emerge visits, about 20 packed cell transfusions, and no less than 14 elevated PTT values that were not acted upon until that very last one, where the mixing study was done. The patient underwent 6 procedures. 4 of them were endoscopy and 2 invasive procedures. This highlights the challenges upstream before the patient even comes to an expert center. And typically, all of the algorithms would advise looking for an isolated PTT and acting on it when there's signs of new bleeding and no pharmacologic agents that would contribute. Once these mixing study, the Bethesda factor VIII are done, then transferred to an expert center, which is what had happened. But one of the problems, one of the whys for this project is a patient like this. And we've seen for many years that prolonged PTTs are not always recognized. Patients and their families have to undergo new and severe bleeding symptoms with delayed presentations. And by the time they're recognized, poor outcomes and wasted resources. Our case is a woman who was living independently in retirement, enjoying it, 3 months and 6 months prior to presentation. She presents to us as bedbound, highly frail and unable to really walk around. So this is the why we want to address this issue. The classic treatment in British Columbia has been to have patients cared for by, maybe 20 or more different hematologists. This is a rare disorder, more like 1 to 2 cases per million population per year, so it's rare. Many hematologists will see 1 or maybe a handful of cases in their entire career. You can imagine this leads to variable practice once these patients are recognized, and the general aspects of treatment are to treat the bleeding first. It's urgent. Some patients are sometimes having life-threatening bleeding, usually to generate thrombin with bypassing agents such as FIBA, listed first, factor VIII inhibitor bypassing therapy, and recombinant factor VIIa. Or we can generate thrombin through the use of an alternate recombinant porcine factor VIII. At the same time, and rather urgently in the historic practice, we need to get rid of that antibody. And we do so through immunosuppression. That contributes to a lot of those infectious deaths. And they may include steroids, as we've heard about already, but other more potent immunosuppressants, including rituximab. So in the congenital hemophilia population, and Dr. Ragney mentioned this therapeutic called emicizumab, a monoclonal or a recombinant bispecific antibody that mimics the activity of factor VIII. So this has been available for congenital hemophilia for several years, but it only became possible to consider the use of this therapy in acquired hemophilia where it will work within the last year and a half. But one of the challenges is that once you all develop a brand new therapeutic, test it, take it through clinical trials, just its availability alone does not guarantee that this therapy is going to have value for patients, and there's a lot of that under the surface, the health system having to deliver this properly in conjunction with a lot of other things happening at the same time. And that leads back to why we need to be collaborative and considerate and also measure what we're doing. So a new pathway is possible where we can avoid some of the intensive bypassing agent therapy, the reduction in thrombosis risk, while maybe modulating our intensity of the immunosuppressant we use in these older patients. What we want to do is create value for patients. We want them to have better outcomes. We want to restore them back to health and independence, even if they're 84 years old and have a number of comorbidities. We want to improve their survival. We want to decrease their dependence on needing others' help and improve pain and suffering. So we need to understand what outcomes are important and start measuring them. We also need to understand what costs are incurred, both to the system and to the patients throughout the journey of this diagnosis, which in about 80% of cases, we can actually control over about 2 to 3 months. So that's very important that we also consider the number of different elements of cost that are part of this journey. So we decided, a collaborative group, to start thinking about the fact that we didn't know any of our outcomes. We had no idea the number of cases in British Columbia. We didn't know the mortality or any of those other factors. And we decided to take a project on that would look at this in a retrospective way, in a study, to understand, using 5 health systems, multiple different chart records, some electronic, none talk to each other, and really establish a data repository so we could begin to improve. And when we did implement this therapy called emicizumab, we would do so understanding its impact, not only on the system, but on patients as well. I'm going to tell you a little bit about where we're at, and I want to highly credit the people listed on the slide, in particular Dr. Chornenky, Dr. Bayanmar, Dr. Levitt, Dr. Preston, DeCoker, Lee, Johnson, and of course myself. We all worked incredibly hard to pull together some of this data just to understand what was the problem. We found actually 46 cases over just over a 5-year period of time. I'm only going to tell you about 42 because literally last week we realized we forgot 4. We didn't know they existed. So it's been such a manual effort. But I'm going to tell you about the 42, median age of 76 years. We had one young patient who was postpartum at 41 and some very old patients who presented. The gender, and going back to the incidence rate, this is about 1.8 cases per million population, which is about what we would expect. So we feel that we've got pretty much the whole population in that 2018 to 2024 time period. We had an abundance of male patients, 27 versus 15 female. This is interesting because the published data would say it's pretty close to equity. It should be about even maybe slightly male predominance. So this is unexplained. We also looked, because BC is a big place. Remember, our case came from like 800 kilometers away. Where were these patients presenting in terms of their health authority, and where did they go to be treated? Shown here are the health authorities from the island on the left, all through to the north on the right, with the 2 biggest, Fraser and Vancouver, obviously taking up the most cases. Those 4 cases are actually in Victoria, so there should be a higher bar there, up to 6 total. And the blue, if you add up all of the light sky blue bars, that's about 80% of patients who transferred to this lower mainland, either at Vancouver General or St. Paul's. Here's the laboratory presentation. Going back to that PTT test, a normal PTT test, depending on the lab, is about 35 to 38 seconds at its upper limit. Anything above that is prolonged. The median PTT was 70 seconds, so very obvious, with a range between 49 and 140. Some of the work that was done to help upstream was working on the different health authorities and how prolonged PTT reports are worded to send to the clinician who's with the patient to help them take that next step of ordering tests or conducting a consultation with hematology. We picked a baseline of 45 seconds, and clearly this data supports that that's reasonable because our lowest in this cohort was 49. We also saw what would be expected for both factor VIII levels at baseline and inhibitor titers at baseline. So this is not unexpected. We saw bleeding that was typical for this condition, largely the major bleeding requiring transfusion, dropping the hemoglobin, being unstable or in a bad spot, was about 43% of cases, what we call subcutaneous. Also seeing a lot more bleeding from the nose, bleeding from the gastrointestinal tract, and bleeding from the genitourinary system. Our overall mortality in this cohort was 29%. So not unexpected, but a little bit at the higher end for what we would be hoping for, with more cases dying due to bleeding in our cohort than the historic cohorts that I mentioned at the beginning, and relatively less infections, and a lot dying usually to malignancy or other events. The length of stay for patients who are in hospital, total length of stay is about 22 days with a range of 8 to 65. Some patients are in hospital a very long time, some lesser so, particularly those that are maybe palliative at the beginning and the condition's not treated. The cost of bypassing agents alone, we did a sort of subgroup study, ranges between about $16,000 per case to up to $2.1 million. These are not cheap conditions to treat, and the median was about $249,000. So this is where we get to that value part, is we're consuming high-value products because it's important to save lives, but we really need to understand what these are doing in terms of delivering value. I wanted to talk a little bit about our prospective work where we integrated the use of the emicizumab right up front in these cases in hopes of restoring health faster, decreasing mortality, decreasing length of stay, and also ideally spending money in a better way so that we're lowering the cost of these expensive agents. But doing so is easier said than done. It's not just a matter of just ordering it when the patient comes in. We had to thoughtfully come up with the protocol. So I forgot to mention the individuals here, myself, Dr. Adrian Lee, Dr. Paul Jensen, Haley Merkley, and our trio of amazing hematopathologists at St. Paul's Hospital were all pivotal in coming up with a standardized way to treat all patients in BC from July 2024 on using the same protocol. We chose measures that are consistent and outcomes and endpoints that are consistent. This is just a little brief process map of what needs to happen during these admissions that are often chaotic and require an intense level of collaboration and ongoing discussion between these individuals. And for sure, a component of their care has moved to the outpatient setting. So now we're collaborating with laboratory, transfusion medicine, and colleagues all over the province. And this is a major shift. Our case that I presented at the beginning is the 11th case we've treated on this protocol. I don't have the long-term data yet because we're still collecting it. We treated the bleeding with 3 days of recombinant 7A. We started emicizumab within 1 day of transfer, and we initiated immunotherapy, a gentler version, very much quickly. And we considered the patient in her transition back to the home center. After arrival in this protocol, there were no further transfusions. The patient was starting to mobilize and was transferred back to the home center after 10 days here. And we're doing weekly factor VIII levels, hoping that we'll see that restore and protecting the patient with emicizumab as long as it takes to restore that factor VIII to its value. So back to collaboration. None of this could have happened without tens and tens of people talking to each other and working on a very complex, busy system to try to address the outcomes that matter to patients, which are largely getting back to a state of independence. We are measuring some patient-reported outcome measures to understand, and also looking at those systemic costs as well, in particular to justify the cost of these novel agents and the offsets that they allow us to provide in terms of decreasing the costs of other therapies. So it's been a great pleasure to present to you today. If you're interested in this condition, check this out, and I'd be more than happy to answer any questions either here or in the future. Thank you.
Hi, Shannon.
Hi.
Great talk.
Hey, Tyler.
As a hematopathologist, I'm a little bit appalled at the case you presented and how long it took that to be recognized. And even though you say it was a large center, it's obviously, I think, probably partly what might have contributed is maybe a lack of hematology specialists in the area. And I just wanted to know if you had any comments about, are clinicians aware when they see these bleeding cases that maybe there's virtual consultation options or things like that? Do you have was there any learning that came from this case around that?
Yeah, thanks for the question, and I had the same thought, because we know there's well-meaning, hardworking folks who are at the bedside trying to do the very best, and they're in the lane of what's common, and that's the right thing to do. And these rare conditions kind of come at them out of nowhere. I do think that there's a problem in medicine in general in that we have the legacy of the INR. We don't use warfarin for most cases anymore, but yet everyone orders an INR, and nobody orders a PTT. And if they do, we've seen this in our congenital population, they don't look at it. And so we've got some work to do, I think, and I'd love to chat with you and the group provincially of how we could message some of that and create an awareness, almost choosing wisely campaign. We were thinking about a CMAJ article just to kind of say, like, don't forget about the PTT. It's kind of a lost helper that can give you a critical clue. And if you have the triad of a prolonged PTT, the patient's not on any blood thinners of any kind, and they're bleeding, this is something that has to be better recognized.
Thanks.
Ben.
Hi.
I have a comment and a question. The comment is that that sentiment about that really prolonged process to diagnosis. The prolonged process to diagnosis is shared. I've definitely had, endoscopists, GI specialists that are saying, I just need to do one more scope and then I'm going to find the bleeder, but that's not the problem. But my question is, in your cohort, in that retrospective cohort, did you look at, the etiology, like how many were idiopathic, how many were cancer, how many were autoimmune, and does that match with the registries that are out there for this condition?
Yeah, great question, and we did. So at 2 years, we're looking at about 65%, which were idiopathic. And that's actually a bit lower than the reported registries, where it's about 50%. Now, that could be, we just haven't had long enough for those states to emerge. But we do seem to have more idiopathic, and we're not sure why that would be. unless it's, some infectious cause, some insidious event that was not detected prior to presentation. And this is retrospective too. So in our prospective cohort, it'll be much easier to kind of comb through the records and make sure everyone's done those due diligence investigations.
Thank you for that, Shannon. I'm curious if these factor VIII antibodies ever have an effect on von Willebrand factor, and that might be contributing to the severity of disease.
Yeah, I often get the question, and I think you're kind of asking it, where people ask, well, why is the bleeding so different in acquired hemophilia A from congenital hemophilia A, where the patients pretty much, if you measure their factor VIII, it looks the same. Even patients with congenital hemophilia A who have inhibitors, their bleeding is completely different from this situation. And I think the plausible answer is that the antibody is different, and we know that in the lab it has different kinetics than in the congenital situation. And I believe, and I think others have postulated, that there must be different hemostatic systems in different body regions, and that for some reason, perhaps these antibodies are interfering with the VWF factor VIII effectiveness, and we see all this mucocutaneous bleeding that we don't tend to see in the congenital inhibitors. But I've never seen a elegant study that's proven that. But why these patients are so susceptible to subcutaneous, massive subcutaneous bleeds, and the others is a bit of a mystery. But I think you're absolutely right.
That's a very interesting point. So are there studies of factor VIII, either their multimer structure, von Willebrand factor, either multimer structure or function or anything like that in the acquired hemophilia A?
To my knowledge, no. We always measure the simple tests, the antigen and the activity, but we in our center at least don't send off those more elegant studies to understand. Usually the von Willebrand levels are elevated. These are older patients who've had, issues, and so they're often greater than 150%. So we lose a bit of accuracy there too. But I'm not aware of any animal model or an alternate model of acquired hemophilia A. There was a primate model used for the development of emicizumab, which is kind of wild. So acquired hemophilia has always been in the kind of development stages, but I don't know if they studied any of the VWF specific
I guess
measures.
another potential reason that the bleeding is different than congenital is just the age of the patients in general.
Yeah, I think that is certainly possible. We do see, in our younger postpartum patients, we see similar patterns. So when we take away that age, with that rarer, smaller group, we tend to see the same type. And often in those patients, of course, it's vaginal or bleeding from sites that the delivery has injured, so to speak. But I wish we did understand it better, because I think that might lead us to more effective therapeutics. I do have to say, though, emicizumab works a lot faster than we would think based on the pharmacokinetic studies. So we're seeing onset within a handful of days. You saw we only needed about 3 days of niastase. So that is fast. So I think there's something about the way it's generating thrombin that may be key in these patients.
Following the question from Ed and Jose, I would suspect that maybe endothelial cells or some other hemostatic process may differ as the congenital versus acquired. So is anybody started this multiple von Willebrand factor to start these ladders, comparison between congenital versus acquired? That's number one. Number two, is antibody start white blood body of the endothelial cells to see whether there is any difference between these two groups?
Yeah, and kind of ironically, I think you come from the center where you have the best chance of doing that. I don't think anyone in Canada sees more cases than Michelle Schultzberg and Jerry Title at St. Mike's Unity Health. So, I think that's absolutely a place where that kind of volume and that scientific approach could be done.